Hello, welcome back to another episode of Ask the Doctor with Dr. Jeffrey Sherman. Today, we have an important episode on colonoscopies and why they are so important for your health. As of today, Thursday, June 11th, the CDC reports there being 1.99 million confirmed cases of COVID and 112,000 deaths caused by COVID-19. Today, we're here with Dr. Sherman, who is a gastroenterologist.
Thank you. Nice to be here.
Close enough. And we're going to discuss colonoscopies because around what age should people start doing colonoscopies?
Right now, the recommended age from the AMA and ACG has gone down from 50 to 45. So if you're 45 and above, it is recommended to get your first screening colonoscopies, provided you don't have any other risk factors, family history primarily, or other prior symptoms or complications. But in general risk population, age 45 now is when they're recommending to get your first colonoscopy examination.
I guess a better question I should have asked is, what is a colonoscopy?
Colonoscopy is a camera that goes in through your rectum and your butt and takes pictures and videos the inside of your large intestine or colon, which, because of its slow motility, is a risk for cancer and precancerous growths. The colon moves pretty slow. The stool and bacteria are up against the walls of the colon all the time, and that is what can trigger mutations and cancerous cells in the colon lining. And that's why we want to look at the colon, because there's a chance for cancer and cancerous lesions and precancerous lesions to form due to the fact that, like I said, it's a slow-moving digestive organ. Yeah. The small bowel, in contrast, is a much more fast-moving organ. It has 20 feet, and you can. It takes about 8 hours for material to enter the small bowel and then exit the small bowel 20 feet later, and therefore does not have the risk of cancer.
That's the small intestine.
That's the small intestine. It takes 8 hours to run 20 feet. In the colon, it takes about 8 hours to run 3 feet or even 2 feet. So it's moving much slower, and as a result, you're at a higher risk for cancerous cells and trouble down there.
So you talked about lesions and growths. What do they kind of look like?
You have the full-on cancer tumor, which is a unusual, irregular, ulcerated, mass of blood and ulcer. I mean, that sticks out right away. That you'll take biopsies of. You can't do anything about that other than biopsy it. There are polyps that you will encounter, and like I was in my experience, I think about 40% of average risk screening patients have polyps, so it's not a small number. You want to get these polyps out. You can encounter two separate kinds of polyps. One, which is just a little bump along the surface of the colon lining, the colon surface, what we call a sessile polyp. It's just a raised little mound, if you will, up against the surface that we can pluck off with our forceps, with our biopsy forceps that we're able to push through the channel. There's a second type of polyp called a pedunculated polyp, with a P, pedunculated. That's got a little tree trunk attachment to the surface of the colon, with then a large flowery tip.
Flowery tip.
Like the broccoli, where you have the stalk and then the big, fluffy part at the tip. That's the potentially cancerous part, and that stalk is not cancerous, and that's how we burn it off. We grab the stalk with our burning device and snare it out or burn it.
Whoa.
And then retrieve the polypoid tip and send it to pathology labs for analysis.
That's crazy. That actually grows in there.
Yeah, and they can get kind of big. That stalk, the stalk of the polyp, has at least one good size artery going through there,
Whoa.
then feeds the polyp the blood supply it uses to grow, and that's so that's why when we're doing the snare, it's a heater probe that acts as a you know a blood clotting device. It burns the blood vessel, so it contains the bleeding.
I remember earlier you were saying that the reason cancer is so much more prevalent in the colon, in the large intestine, is because it just moves things slower.
Right.
Does that mean that people who have constipation, chronic constipation, are at higher risk?
Yes, exactly. I mean,
Oh, okay.
they are moving slower. They're a little bit of a higher risk. The colon's moving slower. More water is being absorbed, and the stool's getting harder. And that bacteria of that hard stool is just rubbing up against the surface of the colon. Not only on the left side, but in the middle of the colon, a little bit more on the right. It's just overall more exposure, and so they're at a higher risk. So those patients should be frequently colonoscoped, even in the setting of no polyps at all. They should get regularly screened.
Yeah.
I would say every 3 years.
Right, because how often does someone have to do a colonoscopy once they're in the age that they should be?
You start. I go a little bit more often than most. In the age range, you look at you take a few factors into consideration: the patient's age, the patient's family history, and the presence of prior polyps and the type of prior polyps. So,
Okay.
for example, if a patient is completely clean, no family history, comes in at age 50, they're on the younger side, and they have no polyps, I give them 5 years recall time. If that
Okay.
patient comes back, has a polyp or two, I give them 3 years recall time. If a patient is in their mid 60s and they're polyp free, I would still err on the side of bringing them back a little bit earlier. I would give them a 3 year recall time. If a patient has a family history, they're going no more than 3 years at any given time, polyp or not. So you take those factors into consideration: the patient's age, the presence or absence of prior polyps, and the family history, and somewhere between 3 to 5 years. There's the other cases who are doing colonoscopies more on a yearly basis, those colitis patients and patients who have other things going on. But in terms of just all things being equal, in terms of the colonoscopy looking for cancer and polyps, every 3 to 5 years is the correct recall time.
Right. So if someone has a family history of colon like cancer or
Yeah.
chronic constipation, those might be different in that they should be doing a colonoscopy every 3 years, but should they start getting colonoscopies earlier than the age of 45?
Yes. As a general rule, you take the patient, you ask the patient, which, it's mainly a parent, a first degree relative, a parent.
Okay.
Okay. A grandparent. Yeah. You want to know that too. And believe me, I will, scope patients on the earlier end if they have a grandparent. But in terms of first colonoscopy, the age at which to get it, you ask the patient, at what age was your parent diagnosed? And then you take
Okay.
10 years prior to that. And that's the first age you get a colonoscopy, or age 45, whichever is sooner. Okay.
Okay, whatever sooner.
Yeah.
I
So if
see.
your parent came down with, colon cancer, if a patient had, then it's age, 52, you take 10 years earlier at 42, and you would go at age 42.
Okay.
So sometimes, the younger colon cancer patients, that's more likely a genetic link. Age is a risk factor for colon cancer. So if you're getting colon cancer at age 80, 75 to 80, if your mom or dad had it at that age, it's not exactly the same as if they had it at age 50 or 47. You know what I mean?
Okay.
But you still want to go no later than age 45, and even sometimes as early in the mid to late 30s.
And so if is it a 10-year difference? Is the reason that you start doing colonoscopies 10 years before your parent got diagnosed with cancer. Is that because it takes around 10 years for cancer to develop in the
It
colon?
can. Some of them are much quicker than that, so you want
Oh,
to know about it sooner yet. But it
okay.
can take. Some tumors are slow growing. A 10-year tumor would be that, and some are not. You want to just make sure you get all of them. You get the slow and the fast if you go within 10
Yep.
years. So you want to catch all the possibilities in that window, and you keep those patients coming back every 3 years, regardless of presence of polyps. Family history, it's every 3 years, for the rest of their lives. And I guarantee those patients will not follow in their parents' footsteps. They won't get colon cancer on my
Yeah.
watch if they come every 3 years.
Yep. I mean, that is the point of these screening tests, is to prevent the cancer from ever happening. Because, I mean, cancer is it's a slower disease than other diseases that like caused by infections. So
Right.
we have a larger window to prevent them from happening in the first place.
Right. Yeah. When I say slow growing, 3 years is fast. In real life, anything growing in 3 years seems slow. In cancer terms, it's pretty fast. But you want to get things checked out as,
Right.
as, as and often as possible.
Are there other conditions that can be checked for colonoscopies, like not just cancer, but some other thing?
Yeah, ulcerative colitis, Crohn's disease, inflammatory bowel diseases uh, need sometimes to see how inflamed the patient's colon is. Those are patients with inflamed colons or small intestines, and we go in there and we can see the inflammation, the degree of inflammation along the
Okay.
colon surfaces, and take biopsies of that, looking for bacteria, viral inclusion. Certain viruses can form in those patients, so the biopsies tell a lot of information, and just the way the colon looks endoscopically tells a big story too. So in Crohn's and colitis patients, you want to take a look in there frequently. Patients with diarrhea sometimes have a condition called microscopic colitis,
Oh,
where the colon cells are not arranged properly, and as a result,
not arranged
diarrhea,
properly.
bad diarrheal illness can ensue. And you want to take some biopsies during a colonoscopy to see if that patient has microscopic colitis, because certain types of microscopic colitis require different types of treatment, whether it be with steroids or other anti-inflammatories. So that's another condition you would use the colonoscopy for diagnosis.
Yes. And so when you were saying there about the cells being arranged differently, is that are there because I know that the colon absorbs water from the stool, and you said that if people have this microcolitis
Yes.
condition, they have diarrhea. Is that potentially because like the cells that absorb water are in a different location, and so they can absorb water?
Yeah, the layers of the colon are shuffled, if you will,
Ooh,
and there's several layers: the muscularis mucosa, the there's like 3 or 4 different layers. But in collagenous colitis, the cells are layered wrong, and in microscopic colitis, the cells are layered wrong. And there's one in particular called collagenous colitis, where there's a
whoa,
little tiny layer of collagen there, and that's the
collagen.
reason that water can't get absorbed. So, right, in microscopic colitis, the cells are misarranged, so the absorbing cells are not in contact with the fluid in the first place. And two, collagenous colitis, there's this layer of collagen blocking water absorption. So as a result, the water does not get absorbed back into the bloodstream. The water stays in the colon lumen, and then empties, and then you poop out a lot of water, or in other words, diarrhea. And that is the main symptom of a microscopic colitis.
Yeah. Is the microscopic colitis like a local thing? Because or does it arise as well? Because it sounds like it should be innate to this person's structure of their colon, but at the same time, it's a condition.
Yeah, it's a condition. Your colon's pretty smart. It generally arranges the cells, uh, you know,
Yeah,
normally. It
correctly. It's
can
good
be
that it does.
local. It can be in one spot, or it could be throughout the entire colon. But it only needs to be present in one area for those symptoms to occur.
It sounds
Even if
crazy.
if 20% of your colon, if 80% is normal, and then 20% has this microscopic colitis, that 20% is going to carry the day and cause diarrhea. You need the whole colon to be on board with itself to be working right. It may not be as severe as if the entire colon were involved, but
Right.
you would still feel symptoms and still want something improved upon. So Uh, that's why when you're looking for collagenous or microscopic colitis, you're taking random colon biopsies throughout the entire colon, the right side, the middle, the left, and you're just plucking away all over the place and getting as many samples as you can, because the more samples you can, the best you can pick up the defect.
Um, so what what kind of symptoms can a person feel that they should tell their doctor about to get them a colonoscopy maybe sooner? Is there
Well, we
anything to
all
look out
know that at
for?
age 45, you want to get a colonoscopy, whether you're feeling symptoms or not. So most of the time, the patient says, "Hey, I'm feeling great. My doctor says, I need a colonoscopy, so I'm here." But the answer is no to all my questions. Are you having any, all my questions? Well, the questions are you having abdominal pain? Change in bowel habits, and blood in the
Okay.
stool. What are those things? Well, blood, you'd see blood. You would see red blood. You would see maroon blood. So if you're seeing that, that's a red flag to go see your doctor. Now, does that mean cancer automatically? No, but you shouldn't be pooping out blood, so you want to make sure you get ahead of it. So there's blood, abdominal pain. Either jumping around abdominal pain right to left, left to right, or consistently
Whoa.
on one side.
Directional.
Report that to the doctor and say, "Hey, I'm having this left-sided abdominal pain." That and then we talked about in previous episodes, good history, what triggers it, what kind of things can make it better or worse. Is it associated with eating? You want to answer those questions. And thirdly, you want to report a change in bowel habits. Hey, I was going to the bathroom once a day my whole life, and now for the last 2 months, I skip a day, or even if I skip a day, then when I go after skipping a day, it's loose and it's not the same as my once a day thing. I'm going, 4 times a week and it's diarrhea. What's going on? So you want to report those symptoms, and whether you're 45, 75, or 25, those symptoms are something you got to report. And at any age, something like that would require a colonoscopy. Those are the symptoms to look for, if you were to sense a change and there may be something going on.
Okay. So yeah, like anything with it seems that anything with the digestive system is very complicated, and you kind of have to keep as much information as you can about what you're doing with it, because it goes with like your habits of going to the bathroom and also your habits of what you're eating. Um,
Right. I mean, and that's all good parts of the history too, and you want to keep that available for the doctor.
so in our COVID world, how would getting a colonoscopy be different? There's of course like taking precautions with wearing a mask and all of that, but is there really what's significantly different, I guess?
Uh, the one major hurdle has been that because of the droplets and it can be in stool, the patient prior to coming in
Oh,
has to be tested and be COVID negative uh, to be coming in. Wearing masks, absolutely, and doing the social distancing. We stagger the patients in terms of the schedule. The patients are only several patients in the waiting room at a time. The patients are accompanied by a family member or a friend. Those folks have to wait in the car or come back later. We can't just have overcrowding. But the key is this negative COVID test that the patient has to have prior to the procedure. And not only does it have to be prior to the procedure, it has to be within 72 hours of the procedure, maybe
okay.
84 hours of the procedure, which can be a little tricky. These tests don't automatically always come back the next day. There's like a 48-hour turnaround time with some of these COVID tests. And in the setting of and in the case of a colonoscopy, you got to start prepping and cleaning out your system. And we can talk
That's
about that.
right.
But you got to
That's
start
right.
doing that. And if your COVID test isn't negative yet, I'm not going to have you prep. It's kind of a shuffleboard game. So it's a little bit of a tricky spot. We're going to have to get better at it. But but it but the in terms of cleanliness and um, precautions, there is no better place to get it. There's no better time to get it because everybody's on their toes right now.
That's true. That's true. And I'm wondering if because just because someone has COVID-19, it doesn't necessarily mean that their other conditions don't exist either.
Right.
So I'm wondering if people who do have COVID-19 can even get any kind of other medical checkups. Like if there's a dedicated part of the hospital that's like super disinfected and like for COVID-19 people. I mean, I would I don't know where I'm going with that,
Yeah.
but I guess I'm just bringing up how
You always want to separate the COVID patients from the non-COVID
Yeah.
patients. In the setting of a colonoscopy, if you're COVID positive, you're not coming in to our elective outpatient surgery center. So that's screening right there. In the hospital setting, they separate the COVID wing from the non-COVID wing. Everybody's getting tested upon the ER, whether you're symptom of consistent with COVID or not. So they know where to, triage you, and you want to, and you keep the COVID patients together. And of course, the doctors and nurses and staff are, masked up, N95s and shields and gloves and PPE and all that stuff. And then, not that they're not in the non-COVID area, but at least who is separate and who's not. They're using that rapid test. We don't have that available all over the place just yet.
Oh, that's right. It's some kind of screening test, I think.
Yeah, it's like a 15-minute rapid test. It's not as accurate as the other test, which is a limitation.
Of course.
So, but if positive, you're pretty much positive. You just don't, sometimes there's some false negative squeak by, and that's where it can be improved.
Yeah, okay. But I mean, that's always going to be the cost of speed and accuracy with testing.
For now, right, until we get better stuff, which in the way medicine goes, we always will evolve to it.
I have a neat little side gadget that I was able to get like a couple weeks ago. It's a oxometer, I think it's called. Yes, an oxometer. This is like when you would get on any kind of checkup, right? They would take your vital signs. This is basically the device that they'd put on your finger.
Yeah, we use those during the colonoscopy too.
Oh, wow.
Every patient wears that on their finger just like that. That measures it measures your pulse, I think, number one, but primarily it measures the percent of oxygenation of your blood. So how much oxygen is your blood carrying in relation to how much it could carry at percent? And of course, you want 100, 99, 98. Patients with COVID have lung disease. You slap one of them on their finger, and they could be in the low 80s to high 70s, and that's a sign that they need to get checked out.
Yeah, and that's
During
dangerous.
The colonoscopies, we put that on the patient's finger because the anesthesia we use during the colonoscopy suppresses the patient's breathing. Not only do the patients breathe fewer times per minute while under the anesthesia, but they also breathe much more shallow. So we've got to monitor their oxygenation, and so they don't get over sedated, or we want to that's a tool the anesthesiologists use to determine how well sedated and if the patient's ready for a colonoscopy or not. So the patient's always wearing that. Plus, if there's a secretions or mucus that is preventing good oxygenation, it will show up on that pulse ox, and we can be aware of the patient's struggle or whatever. So most of the time in my patients, it stays up in the high 90s, no problem. If you just put it on yourself just now, you probably noticed it was high 90s or 100.
Yeah, exactly.
Problem. But the patients with the lung disease or smokers,
they're going to have less.
They're 92, 89. I mean, that's not so good. You want it in that high 90s to 100, of course.
Is so like 92. I mean, obviously, if you're a smoker, you're not dead. I mean, you're not dead like yet. So your oxygen level, even though it's lower, it's like you're still able to function, but you're just not functioning, I guess, as optimally as you could be.
Yeah, your tissues are not getting as much oxygen as they should be. They're still functioning. They're getting enough. They're just not getting what they should. So they're kind of deteriorating at a more rapid rate. Your heart muscle has to work extra hard if it's not getting enough oxygen. Your kidneys will deteriorate over time. That's the thing. So you want to keep your lungs as healthy as possible to promote the 100% gas exchange there, so your blood is fully oxygenated to deliver the oxygen to those organs that need it. Well, all organs need it, but those ones that are really important. And when you smoke, you break down that gas exchange lining, and you're just you're breathing room air, but not all the oxygen is getting into your bloodstream. So you're breathing 21%, but it's only supplying your bloodstream with 90% of what it could get. You need that extra 10% too, and your lungs just won't let that happen.
We have a question from the chat about the whole COVID-19 situation.
Yeah.
Are they allowing the person driving you to wait in the waiting room of the surgery center, or do they need to go away and wait for being called?
They need to go away before being called.
Okay.
If it's an elderly person or someone who needs a little extra help in the waiting room, we make that exception. But an
Okay.
able-bodied individual, where most of them are, they get dropped off. The ride is more than welcome to stay in the parking lot or locally and hang out. Of course, if they live nearby, they can go home and come back. If they've driven far away, we're happy to accommodate them with a parking pass for the validation and everything like that. But whereas in the past, the patient's transportation waited in the waiting room the entire visit, that is not the case now. When the patient is ready to be discharged, we call the patient's transportation. They pull the car around, and a representative from the center will wheelchair the person down to the car. So at no time does that ride come up to the waiting room.
All right. I guess that's good. I guess it keeps it safe, keeps away from cross-contamination.
Right. The fewer bodies, the better. Of course, we're still all wearing masks in there, and we're only allowing 4 or so patients at a time in the waiting room, whereas before it was, who knows, 20. I mean, whatever it may have been. But now there's only 4 at a time, and they're separated by a good 10 feet each.
So how should somebody, I guess, prepare themselves for a visit to the doctor about a colonoscopy, and then afterwards, like the prep?
Yeah, thank you for asking that. You initially start with the office consultation. Most of the time, the doctor's meeting the patient for the very first time, so you don't know much about the patient's medical history. You think that most of the time, but not all. I mean, the patient's primary doctor has sent the patient to you, and you thank the doctor for that. In other cases, it's maybe a friend or just an acquaintance. Oh, my friend went to you. I heard you're good, so I'm going to go to you. But you want to get to know the patient in the office. Just do you ask certain questions about the patient's medical history, bowel habits, and things like that. You take a list of their medications. You take a list of their allergies, and just overall medical history, and then you explain the procedure to them, which includes the bowel preparation. That's the least fun part of this colonoscopy. Anybody can come in and get a colonoscopy and do the procedure part. It's the preparation part the day before that's a little tricky. And what that entails is the patient is on a clear liquid diet the entire day. So, for example, if your colonoscopy procedure is on a Friday, Thursday, the day before, you're going to be only on clear liquids. Water, Gatorade, Jello, broth, chicken broth, bone broth, soda water if you want bubbles, things like that. No orange juice, which is cloudy, and no dairy milk or anything, which is clear, right? So you got to be on clears. You got to drink a lot of clears, and you want to avoid red drinks because red can look like blood in the colon.
Oh,
so any red dyes that'll fool me and say, hey, there's bleeding, and I'm looking around looking for something bleeding when you just had cranberry juice the night before. So
no cranberry juice, no Kool-Aid.
Yeah. And then in the afternoon, after you've been on the clear liquids all day, we prescribe a laxative drink, as I call it. It's a very concentrated little solution, not very voluminous. It's only 5 ounces or so, but you drink that. There's 2 small 5-ounce bottles. You drink these bottles at 2 hours apart, and you keep drinking water after that, and that'll give your system diarrhea, and you'll be in the bathroom cleaning out your system for the next few hours, and things will calm down, and then you'll be able to go to sleep. But that clear liquid diet and solution is a little rough because you're used to eating more solid food that day, so you do get hungry.
I mean, that's part of the cost of being able to predict if you have cancer or not, which is a pretty big deal.
It's
Because
totally worth it. It's a little inconvenient for one day.
yeah,
No
just one
big
day.
deal. One day of that. Then the following morning, you're coming for your colonoscopy. In 2 hours, it's over. And by then, you're not even that hungry anymore. You've gone through the rough part the night before. You're ready to just get the test and be done with it. And then you do, and it's easy.
We have a nice question from the chat. I had a colectomy in January to remove a precancer polyp.
Yes.
The gastroenterologist said repeat colonoscopy about 1 year after. Is this reasonable, and would my colon be healed and not hurt by the scope?
In a polyp that has been diagnosed as cancerous or definitely precancerous, something that is either cancer or what we call dysplasia, after treatment of that in the first year, I would recommend a 1 year follow-up colonoscopy. And yes, the colon has healed sufficiently in that year's time to allow the the colonoscopist to advance the scope up to that area. So in general, yeah, it is a recommended interval in a cancerous or diagnosed precancerous lesion to go ahead and rescope after 1 year with precautions and being careful.
That's right, actually. I remember learning like a while ago, I believe, that the intestinal tract kind of replenishes itself quite often, I think.
Yeah, I mean, the colon cells die often, new ones are formed, and that's where the mutation comes in to potentially form potentially cancerous or precancerous cells. In the setting of an operation like the question the viewer asked, the colon, often like the scar on your skin, it heals primarily. So if you have stitches or you have an operation on your belly and you have a scar, that's what happens with the colon. A scar forms there. They use stitches in the colon, and a scar of the colon forms, and it's very tight, just like a scar on your skin is tight.
Yeah.
The scar on the colon's tight, and you can go in within a year, at a year time, and have no problem doing a colonoscopy in an operated on colon.
In fact, don't they actually have similar cells? Like, isn't actually the skin share a lot of similarities with the intestinal tract?
Yeah, similar, not exactly, but similar, and they behave similarly in the way they heal to insult, let's say.
Okay.
And they form a nice meshed scar. So within 1 year, within 1 year is reasonable to do another procedure like that. In case of an emergency, if there's bleeding or something, you can even do a procedure sooner. But if you're looking to give the most time, a year is the sweet spot for that particular situation.
Okay. I think this has been a great episode about the teachings of colonoscopy. Is there anything else that you really want the audience to know, Dr. Sherman?
Yeah, I want to also let you know, and thank you for giving me this last chance. The colonoscopy is not without risk. The anesthesia, as I mentioned, it can suppress your breathing a little bit, but we take precautions there. And then there's the risk of what we call a perforation, or causing a puncture hole in the colon wall. That is a rare occurrence, and it is, how do I say it? It's sort of operator dependent. The more carefree, cavalier doctors tend to have more perforations than the ones such as me, who's very careful, deliberate, and won't push the envelope. Some doctors have to get to the bottom and have to see everything, and they're pushing, and then it's almost, I call them swashbucklers. They're taking the scope and they're doing the sword fighting. Whereas it takes some fine tuning movements and very gentle gestures. That's what wins the race. That's how I do it. And as a result, knock on a bunch of wood, haven't had any perforations. And perforations are a complicated thing because they're damage to the colon and sometimes require surgery and hospital and trouble, and another operation to fix on someone who's 45 or 50 just coming in for a routine thing. Then they're in the hospital a bunch of weeks later, and that's a problem. So you want to be careful about perforation, but I always reassure the patient I'm very gentle, and if something's not happening, I'm not going to force the issue. And as a result, knock on wood, no perforations but patients have to be aware of that risk. And it's the doctors who are a little bit more cavalier that tend to have those. We all don't want them, and I'm not saying the other doctors don't care. I'm just saying that type of complication is sort of operator dependent. You kind of got to get to know who you're dealing with.
Okay. Yeah, I guess because it is a surgery. I mean, is it a surgery? It's like classification-wise.
Yeah, it's a procedure. You're not making a new
procedure.
scar or sewing anything up. You're going through a hole that already exists.
Yeah.
And you know, you got to make smart decisions. If you see a big polyp and you're using your burning device, I mean, those cause perforations too. You got to be smart out there. That's the thing. You don't want to do any harm.
Yeah.
So it's a procedure. You got to be careful. And if you do the right thing and use your right judgment, you won't have any complications. But the patient has to understand the potential risks going into it. But the risk reward, it's no contest.
Right.
The reward of detecting far outweighs the slight risk of anything that may go wrong.
Yeah, you have to remember, this is the purpose of this is to detect if you have colon cancer.
Right.
And it's a cancer, which means that if you do have it, if you detect it early, then you're going to be able to prevent it rather than having to spend the next couple of years of your life dealing with it.
Right. And that's the key, detecting early and knowing that you did all you can to prevent something that's preventable.
We plugged in Dr. Sherman's email at his office so that you can email him about getting a consultation if you have any problems with your digestive system lately. Be sure to bring in the best history you can of what you've been eating and any patterns and all that. And so thank you for joining us today on Ask the Doctor. And if you have any questions, yes, My World Science, you can either ask Dr. Sherman or you can ask us directly at myworldsciencetv@gmail.com. And I will do a little bit of research and find answers to your question for the next show, and which the next show will be Thursday at 3 p.m. And until then, stay safe, wear a mask, social distance, wash your hands, and you should talk to your doctor about ibuprofen-based drugs or NSAID drugs. They could cause risks in terms of your severe COVID infection.
Right.
Now,
avoid those Advils.
Yep. Have a good week. Stay safe. See you next time.
All right. Thank you. Good
Thank
to
you,
see
Sherman.
you.